The in the Pranavahasrotas we have discussed about a few of the conditions. The next of the condition is about the tonsillitis, inflammation of the tonsils, which could be either due to the virus or it could be due to the bacteria. Among the bacterial infection, it's the beta hemolytic streptococcus pyogenes pharyngitis or tonsillitis is the most important from the clinical point of view. Viral pathologies, of course, variable viral pathology can produce the tonsillitis, where the clinical symptoms are quite simple, where there will be pain, fever, and locally the swelling would be there. And the typical features which are described of these tonsillitis and the peritonsillitis, the structures around the area, uvula and so on, even including the pharyngitis, they are described by Sushruta as either Kantashundi or Tundikeri or Adhrusha. श्लेष्मासभ्यां तालुमूलात्प्रोद्धो दीर्घशोफोद्घातबस्तिप्रकाशः तृष्णाकाशश्वासकृतसंप्रदिष्टो व्याधि वैद्य कंठशुंडी इति नाम्ना. It is the typical feature of the uvula. Uvulitis. शोभः स्थूलः तोददोहप्रवाके प्रागुक्ताभ्यां तुण्डिकेरिमगातु. When the same involves the peritonsillar structures, the tonsils and peritonsillar structures, that's the tuндикери. शोभः स्तब्धः लोहितः तालदेशे रक्ताग्नेयः सोदृशो रुग्ज्वराढ्यः. The peritonsillar abscess, the tonsillitis resulting in an abscess is the adhrusha. So Kantashundi, Tundikeri, adhrusha. These are the different stages of the tonsillitis or peritonsillitis conditions. Now, from the practical clinical point of view, it's quite important to differentiate between the viral and bacterial tonsillitis. And majority of the conditions, the clinical examination would be enough. Investigations like culture, throat swab examination, or even the antibody tests are not absolutely necessary in all the conditions. A typical viral condition would be, which is more common in our area, would be there would be usual episodes would be having seasonal, like either winter or rainy season, that's the usual season, or even in summer, those who consume cold drinks and so on, they tend to have these kinds of the symptoms. And the surface, when you look at the surface will be smooth, and the patient would have nasal discharge also. Fever will be moderate. Cough and the uvulitis, it's not only the tonsil, the uvula, the whole of that circular structure around the throat, the tonsils, uvula, tonsils also would be inflamed, and total count is not raised. If you see the peripheral leukocyte count, total count is within the normal limits, which is very common. And in such conditions, my usual treatment would be like that of a Jwaram, Mrityunjaya, Gyardanamtarista would be good enough, and 3 to 4 days treatment would be enough. But bacterial tonsillitis is the other way, where there could be a history of contamination. Majority of these conditions would be due to consumption of some inflamed irritant substances, like mainly these junk food and so on. The area of inflammation is clearly limited. When you look at the throat, you can make out that the tonsils, either it could be single one side or maybe both the sides, but the demarcation of the inflammation would be very clearly limited. Whereas in a viral conditions, it looks as if the whole area has become reddish. Whereas here, in case of bacterial tonsillitis, when you look at the area of inflammation can be easily made out. Surface of the tonsils usually would be rough. Occasionally, even you may be able to see the pus. In patients who have a repeated episode, there could be even constriction. The tonsils may be constricted, fibrous. The surface would be rough, and the tonsils may be even fibrous. That's it. High fever, the patient would have high fever. Lymph nodes are usually enlarged. Total count is raised. In all such suspected bacterial conditions, it's absolutely essential to study the ASO titer, anti-streptolysin O titer, because that is one of the factors which can result in the long complications. I will come to that part next. Now, in such conditions, the treatment has to be prolonged, and the usual treatment would be Mrityunjaya, Triphala Gugul, Gandhakarsayana plus Amritaristam, maybe Triphala gargling locally would also be useful. Treatment has to be prolonged, longer duration. Now, the duration of the treatment also is depending upon the degree of tonsillitis. To assess the degree of tonsillitis, the standard protocol is the Brodsky this table or Brodsky's standard, where it is related to the ratio of the tonsils to that of the oropharynx. When the tonsils are within the fossa and you do not see that tonsil, that is what we call as 0. When the tonsils occupy less than 25% of this, as you see grade 1, where it is the total occupation of the tonsils is less than 25% of the whole diameter of the oropharynx. When it occupies in between 25 to 50% of the oropharynx, then it is a second degree. Third degree is when it occupies 50 to 75 degrees, and the fourth degree is when it is more than 75 degrees. Now, these degrees of tonsillitis would have some importance in the prediction of the prognosis and the outcome also. Particularly in case of the bacterial tonsillitis, this kind of a huge swelling is common, and most of the times the patient would have a recurrent history. In such conditions, whether the patient would require a surgical treatment, whether the patient can be managed medically is the other issue. Most of the patients up to the third degree can be easily managed with the same protocol, depending upon the conditions, presentations. And fourth degree is comparatively rare. You may require a surgical intervention in that condition. And the antiseptolysin O titer is essential. It has to be done, test has to be done in all the patients, particularly if the patient is a younger age. And the normal levels of O titer, ASO titer, would be varying according to the age. Now, usually what happens is when you refer a patient for the investigation, our laboratories would give a standard value. They do not give that value which is variable to the age as such, but ideally there could be a significant variation in the ASO titer according to the age. Very the newborn, the rule is it's the same as that of the mothers. And 6 months to 2 years, it's less than 50 units. 2 to 4 years, 160 units. 5 to 12 years, 170 to 330 units. Having a moderate level of high level of 170 to 330 ASO titer in an age group of 5 to 12 years is not necessarily a high sign of the serious pathology, which do not require treatment. Now, this is one of the usual errors which is done. Most of the times, patients at the age group of 5 to 12 years, the children, school-going children age, they are subjected to ASO titer somewhere, and if the level is just higher than 170 or something around, then the people would consider this as a patient with the ASO titer positive, and penicillin prophylaxis is done, and it's always considered as a possibility of rheumatism or maybe the scarlet fever conditions. In adults, it's around 160. That's the important issue where common errors are being done. Now, as far as the clinical management of tonsillitis is concerned, there is a central criteria, and I just modify the central criteria based upon that. The criteria is in the present the central criteria in a patient tonsillitis, if the body temperature is more than 38 degrees centigrade, score is 1. If there is no cough, again the score is 1. And if swollen and tender cervical nodes are there, then the additional 1 score. Tonsillous exudates, there is a significant exudates over the area, then again the score is 1. Then of course the age of 45 years or older is -1 score. Now, if you make out that cumulative score, the center score, if it is less than 3, then the suggested treatment is a symptomatic treatment. Now, in the patients who have less than 3, now less than 3 is simple, where you give that Nrithinja, Trifala, simple, that would be the management. If the score is more than 3, then I would consider, instead of going for the throat swab test, now the standard protocol is a rapid detection of the antigen test by Streptococcus pyogenes. ASO titer has to be done, but I would not go for ASO titer. I would be preferring to go for only total count, and if the total count is less than 16,000, in that condition, the usual management would be again same, Mrityunjaya, Trifala, the same usual treatment would be enough. If the total count is more than, suppose in such conditions, if the count is less than 16,000. But if the patient is ASO positive in terms of that age and the relationship of the ASO level, and the patient also has tachycardia, in such conditions, antimicrobial therapy may be required. A short course of antimicrobial therapy, either penicillin or amoxicillin, may be required. So, antibiotic would be required either if the total count is more than 16,000 and ASO positive. In such conditions only it is the antibiotic would be required. Otherwise, antibiotics are not necessary. And it's not absolutely this and of course, along with the antibiotic, if we give Mrityunjaya Triphala Kasayana, the total duration of the treatment can be reduced, and penicillin prophylaxis is absolutely not necessary in such conditions, provided the patient takes care of the food and the lifestyle. Suppose if there are complications like peritonsillar abscess, then of course the antibiotic would be necessary. Antibiotic as well as a drainage may be necessary. Tonsillectomy indications are, now this is standard, what I have presented is the standard protocol of the indications for the tonsillectomy is more than 6 episodes of streptococcal pharyngitis confirmed by positive culture in 1 year. If there are, simply because a patient had 1 episode of streptococcal pharyngitis, tonsillectomy is not necessary. Only when it is having an episode of more than 6 episodes or 5 episodes of pharyngitis in 2 consecutive years, continuously every year 5 episodes, or 3 or more infections of the tonsils and adenoids per year for 3 years in a row, if there is a continuously persisting for more than 3 years, in such conditions only tonsillectomy is indicated. And chronic and recurrent tonsillitis associated with the streptococcal carrier state has not responded to beta-lactamase resistant antibiotics. If the patient doesn't respond to the antibiotics, then the tonsillectomy is indicated. These are the standard indications, and majority of the patients can be managed successfully to avoid these indications, and these indications can be prevented and surgery can be avoided. So, in a large number of patients where otherwise surgery is indicated, surgery can be avoided with our treatment like Mrityunjaya Triphala, and even penicillin prophylaxis to avoid that ASO rate, this rheumatism also is not necessary. Only in the patients who have an established rheumatism where there is a definite cardiac involvement, maybe the other protocols could be tried. Now, the other variations of this would be peritonsillar abscess. In the peritonsillar abscess, the typical features would be Galet Shopam Kurte Prabudha Shleshmanilo Shwasajopam Barmachitam Dustar Mendahu Balasa Sundam Nipuna Vikaram. That's the balasa where the child would have a abscess where there would be huge bulging, swelling at the area. Even it can block the respiratory tract as well as the gastrointestinal tract opening, and in such conditions, of course they are rare, not so common as such, and if the patient has any of these presentations, definitely that's considered as Asadhya Vaishushuddha. In the present situation, definitely one course of antibiotic is required, and surgical intervention like either the drainage or maybe the tonsillectomy may be indicated. Then another of the features where you may have to be careful would be a patient having unilateral tonsillitis, and if the child has a sleep apnea, then you have to be careful. That's one of the conditions which can result in more serious complications. When there are rheumatism, the rheumatic features would be pain, patient having joint pain, fleeting pain, tachycardia, murmur, or chorea-like conditions, irregular movements of the body. In such conditions only you may have to have a more energetic treatment. Again, even in case of the rheumatism, I don't say that this penicillin prophylaxis is absolutely necessary, but the treatment should be prolonged. Mrityunjaya Triphala Gugula has to be prolonged, or Agni Chikitsa Ksharabhasri also may be indicated in such conditions. Now, some more of those variants of the tonsillar pathologies which can produce confusion in the clinical practice and which should be very carefully ruled out would be conditions like herpangioma, herpes resulting in the herpangina, where the herpes presenting with the pain, or candidiasis, or maybe rarely carcinoma, tumors also can occur. Now, in such conditions, the description of this in our text is क्षिप्रोद्गमा क्षिप्रविदाहपाका तीव्रज्वरा पित्तनिमित्तजा स्यात् सोतो निरोधिन्यपि मन्दपाका गुर्वी स्थिरासा कफसंभवाय वै पित्तज conditions of the this galogha are the presentations of herpangema, where the typically herpangina, where the patient would have typically vesicular eruptions over the area, moreover the palate and soft palate area, and including the tonsillar, peritonsillar area. Usually tongue would be free, tongue would not be involved in such conditions, and sudden onset and acutely painful. Patient may have systemic fever, and that's the typical presentation. And in such conditions, the treatment would be Kamadugha and Paripatha. It's a herpes variant. Actually, due to the herpes in the oral cavity, these lesions would occur. Then candidiasis is one of the conditions which is we have to be very careful, and it always occurs only when the patient is having some immunocompromised conditions like maybe HIV or tumors or so on, and rarely purely unhygienic conditions are the patients who are significantly malnourished. Candidiasis tend to occur, and when you look at the condition, it will be like there will be rough surface, and even there could be fleshy tissues present over the area, that yellowish slough surface present, and it will be fragile and tend to bleed. The clinical symptoms of these are very much similar to that of the Rohini mentioned in Sushruta. जिह्वां समन्तात् घृषवेदनावया मांसाङ्कुराः कण्ठे निरोधिनः स्युः तां रोहिणीं वातकृतां वदन्ति वातात्मक उपद्रवगाढं युक्ताम्. The typical presentation would be same, where there would be severe pain and swelling, even it can produce a obstruction to the respiratory tract. The condition would be, it's quite important is to assess the basic underlying pathology and whether that underlying pathology can be managed or not. So management of the underlying pathology like HIV or maybe tumors or so on would be necessary, or in the patient who are malnourished, the nourishment has to be taken care of. Once you have taken care of those underlying pathology, Gandhakarasayana Khadirajista Triphala gargling, Triphala Kotha gargling can help to a certain extent to ameliorate the symptoms. Candidiasis, it's not a specific treatment for the candida, but it's about the preventing the underlying pathology, which is the most important. And once it is done, the management further can be managed with the Gandhakarasayana Khadirajista Triphala gargling as such. Then carcinomas in the area, comparatively rare, but there would be a firm, fragile nodular swelling either at the midline or over the tonsillar area. That roughness and the fragility itself is a characteristic feature. The patient would have a comparatively less pain, the pain would be less intense, but there could be bleeding at the area, difficulty in swallowing, and even occasionally something episodes of neurological pain, neuralgia like symptoms may occur occasionally, and that's the typical presentation of either Raktaja Tundikeri or that of the Kantashaluka. Kantashaluka mentioned by Sushruta is a Kolastimatraha Kapsambhavyo Granthi Gale Kantakashu Shuka Bhutaha Karaha Stiraha Shastra Nipat Sadhya Tam Kantashaluka Mili Bhuvanti. Sushruta has obviously said that it is a Shastra Nipat Sadhya. Only surgical treatment is possible in such conditions. That's one of the possible description of the tumor. Or in fragile tumors, it's about the Raktaja this variety. Gambhira Paka, Aprativara Vidya, Trizoshalinga, Trasambhava Syat, Spotachita, Pittasamanalinga, Sadhya Pradishta, Vijratmakam, Ether. Raktaja Vyadhi, Raktaja Mukhapaka also can present in the same manner. So that's about the tonsillitis. The next part which we get in would be the laryngitis as such. Laryngitis is again the same infective pathology descending down. See, till the level of tonsillitis, the tract is considered as upper respiratory tract infection. Maybe we may have to form a word like upper Pranavahasrotas, which is not really a standard one, but we may use that word. Whereas the next part would be what we call as lower respiratory, LRTA, URTA and LRTA. These are the two words which are used. And once it involves the larynx, the typical clinical presentation would be hoarseness of the voice, malaise. Majority of the patients have a laryngitis only as an extension of the other upper respiratory tract infection. Usually the patient would have initial clinical symptoms of either the rhinitis or maybe occasionally pharyngitis or tonsillitis. Then it results in the hoarseness of the voice and malaise. Then you have to suspect the laryngitis has occurred. In addition to these inflammatory causes, laryngitis also can occur due to either GERD, quite important. Many of the patients have gastrointestinal tract reflux of disorder, they may develop the laryngitis, hoarseness of the voice could be presented. So history taking is quite important. Then it could be even produced due to pollution, vocal trauma, like patients who sing or maybe speak for a long duration. Then inhalers, consumption of these, taking inhalers for a long duration, persisting that consumption of the inhalers also can result in the laryngitis. Occasional drainage can occur. The treatment protocol, standard treatment protocol is inhaling humidified air promotes the moisture of the upper airway, helping to clean the secretions and exudates. So steam inhalation is one of the standard protocol for the treatment of laryngitis. Voice rest is suggested, although this recommendation is nearly impossible to follow. If the patient must speak, soft light intonation is best. He has to speak as less as possible, and whispering is not suggested. When you try to do the whispering, there could be hyperfunction of the larynx. So when you say low voice, it should be low voice but not whispering. Then this again I have copied it directly from the standard protocol of the treatment globally. The standard guideline treatment suggests antihistamines and corticosteroids should not be given. Prevailing data do not support the use of antihistamine and corticosteroids. If a patient uses these medications, he or she may have the false impression that the laryngitis is resolving and may continue to use his or her voice, leading to further insult, and the drying effect of these medicines may also be deleterious. This sentence I have copied as such from a standard guideline scope to highlight this issue. And a very common error which is done in the clinical practice. Most of the times this error is done. But as far as the ideal prescription and my prescription would be, in all patients of tonsillitis, of course, voice rest is one of the things, and then the other is the steam inhalation is also one of the standard protocol, and along with that, the prescription of Mృత్యుంజయ Triflocucul Amrita would be quite useful. To reduce the distress, Khadirativity or Lavangativity for chewing is one of the standard protocol, which can reduce the symptoms of these laryngitis significantly. If a patient has symptoms of laryngitis persisting for more than 3 weeks, a laryngoscopy is a must. So up to 3 weeks we can try. If the voice is remaining hoarse even after 3 weeks of the treatment, then a laryngoscopy is must. Where there could be some underlying pathology like tumors or maybe tuberculosis and so on. Some other serious pathology could be there. It may not be a simple case of laryngitis. So laryngoscopy should be done after 3 weeks. A reflux laryngitis is the other way. To a patient having the hoarseness of the voice, to confirm whether that is due to the reflux laryngitis or not, there is a standard guideline. The standard guideline is the questionnaire with the questions, and depending upon the score which you get as answer as the questions, 0 to 5 is the grading of that answer, that question, like whether hoarseness or a problem with your voice, whether it is only hoarseness or whether you are having a difficulty in speaking. Usually the reflux laryngitis would have only the hoarseness. Patient would not have a difficulty in speaking, pain would not be that much. A clearing of your throat, whether the patient has a feeling like a continuous throat has to be cleared or not. In a reflux laryngitis, that would be less common, whereas in case of inflammatory laryngitis, that patient would continuously feel like clearing the throat. Then excess of throat mucus in a postnasal drip, which is also more common in case of the other tonsillitis, whereas reflux tonsillitis, reflux laryngitis, it will be less common. Difficulty in swallowing food, liquids or pills. This is more common in case of the reflux laryngitis than the other way. So depending upon this course, you can make a coughing after you are ate or after lying down. Now, coughing after consumption of food or coughing on lying down is also a typical feature of the reflux laryngitis. And breathing difficulties or choking like episodes also are more common in the reflux conditions, reflux pathology. And troublesome or annoying cough is also a typical feature in case of reflux laryngitis. Sensation of something sticking in your throat or a lump in your throat, that's again a sign of inflammatory laryngitis. Heartburn, chest pain and indigestion or stomach acid coming up, these are also the signs of reflux laryngitis. Based upon these questionnaires, you can decide whether it's a reflux laryngitis or not. If you are suspecting reflux laryngitis, my prescription would be Sudhshekara Kamandaku Gudantya Vipatikara. The hoarseness of the voice can be treated with these drugs, which generally are considered as drugs used for something like gastrointestinal tract. Generally, I think that kind of a indication or that kind of a description is not very accurate Ayurvedic point of view, but that's the usual thing. But the patients can be cured, managed, and many times this occurs because most of the times the patients are misdiagnosed and the patients are given antihistamines, but times even steroids also are given. So such patients who have primarily the gastrointestinal tract pathology, they can be better managed and the results will be dramatic. So a clinical differentiation of reflux laryngitis as well as inflammatory laryngitis is necessary. At the same time, if the symptoms are persisting for more than 3 weeks, then a laryngoscopy is needed, which may have to rule out other conditions. Then the next condition which we discuss would be tracheitis. Tracheitis is again one step below, where the patient would have more of pain in the chest, cough and pain in the chest. Hoarseness of the voice may be presented, and the typical presentation would be persisting dry cough and non-productive cough and pain in the chest which may occur, and even there could be a wheezing sound produced, loud sounds of wheezing may be produced. On auscultation, respiratory tract, the respiratory sounds may look normal, and this is described as the Rasthanka Murtha Udara Pashashuli Kshamanana Kshina Balsarojaha Prasaktam Anta Kapamiranena Kaser Shushkam Sarabhedayuktaha Uro Vidaha Jaravatra Shoshihi Abhyarvitaha Tikta Mukatrashartaha Pittena Pitan Vamet Katuni Kasir Sapanduhu Varidakshamanaha, either Vataja or Kafaja Kasa, Vataja or Pittaja Kasa. I will make it as Vataja or Pittaja Kasa Lakshanas. And the treatment would be again same, Mrityunjaya, Sudhshekara, either Lagusudha Mishra or Sitopalagi, or Somasava or Pipalyasava is the other prescription which are usually given. If the patient has a highly non-productive cough, then Sitopalagi is given. If there is a productive cough, some expectorant is coming up, then Lagusudha Mishra is given. Similarly, if there is a loud wheezing, then Somasava is given. If there is not much of a wheezing but more of pain in the chest, Pipalyasava is given. Mrityunjaya Sudhshekara is the usual other common prescription, and the treatment has to be a bit longer than the usual. The other protocols like steam inhalation would also be quite useful in tracheitis conditions. That's one of the conditions. Next, when it results in the inflammatory pathology, it results in still lower level, the bronchi, that's the condition where the patient would have what we call as bronchitis. Tracheitis and bronchitis clinical differentiation is comparatively less, but when you have some auscultatory findings like crepitations over the area and the patient may have a high degree of fever, the fever may persist for longer duration, then you suspect bronchitis. And it's the typical presentation of Vata Kapaja Jvara, Saimityam, Parvanam Bhedaha, Nidra Gaurometa, Shirograha, Pradishaya, Kasaha, Sveda Pravartanam, Santapo, Madhyabegascha. These are the persisting fever. Then sputum may be slightly more in such conditions, the sputum may increase further. And the distress in the midline of the chest would be lesser. Patient may have the pain in the periphery area occasionally, but more than the pain, it would be the cough and the sputum which could be the presentation in case of the bronchitis. Auscultatory findings like either crepitations, and usually the crepitations which are fixed, which do not move according to the position, or maybe post-tussive crepitations. Crepitations may be better heard after coughing. So auscultatory findings are essential. Whereas a typical tracheitis patient, there would be no auscultatory findings. That's the basic difference. When you have a bronchitis, the auscultatory findings would be present. When it's only the tracheitis, auscultatory findings of crepitations would be absent. That's the basic difference. And in such conditions of bronchitis, my usual prescription would be Mrityunjaya, Tribhuvanakirti, or Talisadi, or Lagusudha Mishrana, Pipalyasava or Kumariyasava, depending upon the patient's condition. If the patient has a impaired appetite, gastrointestinal tract symptoms are more, and the condition has become chronic, then Kumari is better preferred. In the acute condition, recent onset, duration is shorter, Pipalyasava is a better prescription in such conditions. When the typical bronchitis is established, then the typical presentation would be the sputum would become thick and scanty expectoration. Crepitations are pronounced. Now this is one stage where we may consider this as a kaphajakasa. Pravilapyamane mukhena seedan shirorujartah kapurnadeha abhukta gauravasayuktah kasetu sayana sandrakam kapena. A bronchitis, we generally in the current situation, bronchitis is considered as a single condition. But in the bronchitis, the clinical presentation would change. Like if the patient has bronchitis for a week or so, then the clinical presentation would change where the expectation would become thick and crepitations are more pronounced. Even it can become bilateral, extensive, and even radiological findings may be normal, may show the evidence of mottling. The mottling could be seen. X-ray may show evidence of mottling. Whereas in the early stage of bronchitis, the X-rays are do not show any abnormal. Now that's one of the important issues. So if it is radiologically positive, in such conditions, my prescription would be Mrityunjaya, Tribhuvanakirti, Lagusudha Mishrana, Somasava, steam inhalation, the same protocol. Occasionally, if the condition is persisting and the symptoms are more, then I may add Makardhwaja 1 gram for 1 week to the Lagusudha Mishrana. Makardhwaja, Lagusudha Mishrana and Madhyasti is a mixed together, which also can replace the usual Lagusudha Mishrana as such. So whether Makardhwaja has to be used or not, that would be depending upon the same issue. Acute bronchitis, where the patient occasionally may have sudden development. See, a good number of patients of bronchitis would have a gradual progressive evolution from the upper respiratory tract to the lower respiratory tract, which may take about a week or so. Occasionally there could be presentation where the patient may not have that upper respiratory symptoms initially. All of a sudden the patient may have a cough, chest pain and fever. Now crepitations may be formed, and majority of these patients may have a history of repeated episodes of such conditions, and that's the typical presentation of a Pittajakasa. Pita Nishthivanakshitum, Tiktasyatum Sarameha, Guru Dhumayanam Krishna, Daho, Moho, Aruji Brahma, Pratadam Kasamanascha, Jyotishi Vacha Pashyati, Iskleshmana, Pitta Samsystem Nishchivatya Paitike. That's in the Pittaja condition, there would be more of a thick sputum, which is also a variant of acute bronchitis, and even that can be managed with the same prescriptions. From our prescription point of view, I don't make much change, but in such conditions, Makardhwaja may be added in the beginning itself, if the Makardhwaja Lagusudha Mishrana is prescribed in that condition. In a bronchitis becoming chronic condition, when it becomes persisting for more than 2 to 3 weeks or even more than a week, then gradually the expectation becomes thinner, crepitations become more, even bronchi may occur, which is usually localized at one side. Patient may have a symptom of dyspnea, and when you take the X-ray, X-ray will show the fibrous tissue markings, lines of fibrous tissue markings, along with the mottling. That's the typical condition which we call as the tamaka shwasa. Tamaka kapakasetu syatchet pittanuvandajah pittakasa kriyam tatrethavastam prayojita. That the treatment has to be pittajakasa chikitsa. The same which I said about pittajakasa chikitsa, the same has to be done in such chronic conditions, and my prescription would be same. Mrityunjaya Makardhwaja LSM Madhyasti, Somasava, and the duration of the treatment for the 3 weeks or 2 months, even 3 weeks to 2 months depending upon the chronicity. So when the condition becomes chronic, we consider the issue different. So from the current approach point of view, bronchitis are considered as a single condition and these different stages are not given much importance. The treatment protocol is the same, usual antibiotics and some expectorants. But this may not really produce the same equal results unlike our approach, Ayurvedic approach, where we can assess the stages of the conditions and the stage-wise protocol would be prescribed, which is much more specific. Then one more of the complications which we see quite frequently would be the recurrent bronchitis, when the patient has a repeated episodes of the same, and that is the shwasa, different varieties of the shwasa. Yada srotanti samruddhya malata kapapurvakah vishwagrajati samruddha tada shwasan karoti. In that condition, the typical history would be patient would have a repeated episodes of cough and fever, breathlessness, which can be one episode cured and another episode again within a short duration. The expectation tends to be more and there could be even yellowish, and when you auscultate, crepitations with the rhonchi are seen, and when the X-ray is taken, X-ray shows the established fibrous tissue markings, mottling, which could be even a wider area, extensive area, which is recurrent bronchitis. Again, it's not classified as chronic bronchitis in the present situation. A chronic bronchitis would have a different definition. I will come to that part. But from our point of view, we consider that as a shwasa, and in such conditions, my prescription would be Shwasakutara, Arogyavardhini, Makaradaja, Lagusadhamishana Madhya same. Somasava can be for long duration. Kumariyasava after the episode can help in prevention of further aggravation or further episodes. Once a patient is relieved of the symptoms, to prevent further episodes, I would prescribe Kumariyasava as a Agnidipana. That's one of the conditions. The next part is about another of the condition which you may see as a complication of infective pathology is a bronchiectasis. Bronchiectasis is a infective pathology involving the lung, which would be persisting for a long duration, resulting in a thick accumulation of the pus and the dilatation of the alveoli. Alveoli, they become dilated, and hence the surface area available for the air exchange will be reduced. And when you take clinical history, it will be very prolonged history of repeated episodes of cough and expectoration. Expectoration would be purulent, and one of the typical standard history would be postural drainage. The amount of the expectoration would be more when the patient lies down on the opposite side of the lesion, and usually more at night. And the purulent expectoration, pus-like expectoration is the characteristic feature. And chronicity, condition persisting for months together, that's the issue. When you auscultate, the auscultation will show coarse crepitations, leathery rails at the area. Radiological findings, X-rays are very characteristic, where you see the dilatation, beehive-like appearance, dilated alveoli would be seen, and even there could be slight reduction in the size of the lung lobe, hence the shift of the structures to the affected side can be seen. Air entry to the area can be reduced. Now, these clinical symptoms are characteristically seen in case of the Kshatrajakasa. Kshatrajakasa, according to Madhavanidana, the etiology is Yuddhadyehi Sahasihi Teitihi Sevitehi Ayathabalam Urasya Antakshate Vayuhu Pitte Nanugato Bade Kupitah Kurte Kasam Kafam Tena Sashonizam Pitam Shabancha Shushkancha Garchidam Kwatitam Bahu Stivet Kantena Rudita Vibhinne Majavarasa Suchi Tikshnabihi Tudyamanya Shulina Parva Bheda Jara Shwasa Krishna Vaisarya Pavana Paravada Ivakujan, Paravada Ivakujan. This is one of the important issue in case of bronchiectasis. Parshashulita Sacha, Prama Vidam Ruchi Pakta Bala Varnashti Kshinasisms, Asring Mutratum Sarcha, Pristakati Graha. Chronic complications of the infective pathology are the more common issues, and a patient of bronchiectasis always has a high risk of involvement of the systemic pathology. Either skin changes can occur, osteoporosis can occur, and the patient may have other multiple sources of infections present. In this condition, the treatment protocol is a quite prolonged treatment. The treatment would be the effective palliative measure. Now, I don't say that there would be curative treatment. From my approach part of treatment, The treatment has to be prolonged, very long duration. And my usual prescription will be Mrityunjaya, Suvarnamalini Vasanta with the Langsur Mishrana for 1 week, this for 1 week, and the same has to be repeated. Pushkara Moolasava or Vasakari asava can be given. Viretana also is tried in some patients as such. One of the important issues is that many of the patients of bronchiectasis may have the other systemic pathology like rheumatoid, cystic fibrosis or HIV like conditions, which have to be very careful and they have to be avoided. That's the one of the issue. And the same also could be considered as Kshayajakasa, Vakshavati Matram Hetutiyasya. The same, of course, in Sushruta aesthetic lab, not much of a difference there. Then comes the airway obstruction pathology. I will come to that part in the next session. We will discuss about the obstructive pathologies and restrictive pathologies. And if there are any questions, we will try to answer. No questions. So we will wind up today. We will continue in the next session.